Are you ready with the mic?
I think so. Good. Yeah.
All right, so we got a lot to go through. Has everybody looked at the protocol? You've looked at some. All right, so they're long, but it's not long for any other reason than a lot of protocols. I have a protocol section. I have this little hint, like the Perl section that goes underneath. That's why it gets doubled up in size. So it's not actually that much longer than anything else. Lots of changes. Go ahead and click, please. Next slide. We have a new layout. As you can see, we have a new forward, which covers a few basic things. Important thing is color coded. So you can quickly flip through and see what's going on. We have a notation procedural and then a reference section. Then we have all the state requirements sitting at the end. So everything is eventually going to be hyperlinked. And you're going to click on the med and go straight to the medication section. Right now, we're actually looking at hint. The way they have it set up now is you can click through things on hands heavy through protocols, as well as does the drug calculations for you, and they actually we're taking a strong look at that to our new format of the protocol. Next slide. Within each section, except the OE section, the adult and pediatric are divided into cardiac, environmental, medical, airway, and trauma. That's how they're divided up now. So it should be fairly easy for you to follow and go through. Next slide. So in the forward, these are your basic sections. The delegation of practice change. We now have all the different levels of what you're doing. We do have a new position on scene section. There's actually some stuff that, these protocols are sort of a hybrid between Fort Bend and then what we have. I'm kind of taking best of both worlds and put them together. There's a lot of great legal ease in the Fort Bend protocols, which they paid a lawyer to do, which I cite for our protocols. And they are fully aware. Next slide. We also have a few new things, transportation, determination. You have all these listed out. A few new ones, I think you knew we have a state renal disease during disaster. That was a special protocol that does not get deactivated until a disaster occurs. And even then when it's activated, it's something you're going to have to discuss with me because the city of Houston and Bellaire are not set up for it. So it's really bizarre protocol the state bases have. We do have a freestanding ED transport protocol. That's for disaster only. Again, that's something if you want to go to freestanding, you got to run it through me. You can't just do it. But we think what's going to happen here over the next year, hospitals are doing a strong push. We're going to start transporting in freestandings for a lot of our minor stuff. Next slide. I do have a hospital slide, access slide, which needs to be updated.
Yeah, I need to get some numbers and code.
Perfect. This is the freestanding one. I did want to show you that. It's not active from a day-to-day, but during a disaster. And here are kind of your things. Some of the most important things are patient must be agreeable to transport to a freestanding ER. If your patient does not want to go to a freestanding, conversation is over. Okay. One thing you will notice up there, chest pain. Do that on purpose. Okay. I'm not saying if you have a patient that you're treating for ACS, and you're worried, you're giving them aspirin, they're having chest pain, you think they should go to a freestanding? No. If you have a 12-year-old who just got hit in the chest by a baseball, who's stable, doesn't have the ectopine on the monitor, you think they can go to a freestanding? Actually, I think they're okay as long as they don't have ectopine on the monitor. As long as not throw PVCs or anything great, I think you're good to go. Freestanding. If they're stable, right? So this is where you have to start making. All right, next slide. Here's the deal with today. I am not going to go over every single protocol. A lot of them are unchanged because there really wasn't a need to change them, but a lot of them did change. And I'm not going to go down the whole protocol. I'm going to point out what the difference is in this protocol from what we've done before. It is on you all to study these protocols and know them. Go ahead, next slide. Continue. So this is just a quick layout of how the protocols look, as you see. You have this section on top. On top, rather than writing everything out in paragraphs, what we're doing is trying to simplify it. So I have a history side, symptoms, differential, things to look at, treatment considerations. The other thing to point out is just because I list all medications down here, does that mean you give every single one to every patient? Absolutely not. you guys are smart enough to figure out whatever needs to happen in your patient. So when you see the list of drugs, these are the drugs that are indicated in this scenario, but you have to choose what makes sense for that patient. To your left, you'll see the Pearl section. This is stuff for you to think about and to consider on each patient. And actually, there's some really good stuff in there I would consider reading it. Don't just say, Pearl, I'm not going to go over it. No, actually, there's some really good things. Go ahead, next slide. All right, so let's start. So this is our asystole PDA slide. In cardiac arrest, I'm simplifying things. I am tired of the different drip rates. I tried it from, several people are doing it throughout the country. It's a pain in the ass. So what we're going to do is we're going to have 200 mics per minute infusion of epi. That goes for VFib VTAC. It goes for asystole. It's a little different for VFib VTAC. We'll go to that in a second. But for asystole and PDA, what you're going to do, your obvious first dose is still your push, right? 1 to 10 push of cardiac epi, and then you're going to set up your drip. You're going to start 200 mics per minute, and just let it run. That's what you're going to do. That's the big difference. 3-minute cycles are the same. H's and T's reference. We do have a reference in the back now you can take a look at, which is available to you. I also have stuff listed out there on the left. Interesting things to consider for sodium bicarb. If your patient indicated needs it, you believe they've been down, benefit from a calcium chloride. I say 500 to 1 gram. Usually you're just going to do the 1 gram push. But you may have some incredibly small, tiny, the 60-pound, 80-year-old. You may say, let's try 500 and you're kind of small. That's up to you.
That heavy infusion was still 300.
Still 200 mics per minute.
Yeah, but how do you get that concentration?
So that concentration is done by.
It's 5 1 milligrams into a 250 bag.
Now it's 5 milligrams in a 250 bag?
That gives you your concentration of 200 mics for 25 minutes.
25 minutes is what you have.
Big
Fix that problem.
When he first put it out, it was 10. It was 10 1 milligrams.
So a lot of
Yeah, you need an MDV at that point.
Yeah.
We need to switch that up.
I can, if they have it available.
I'm gonna let you guys figure that out. You just tell me how you want it, and then we'll make.
No, we can leave it like that, but I'll see if I can find that 30 mil.
I'll let you guys figure that out. So, any questions on this slide? Where do we want? Next slide. Go back. Next slide. Perfect. So this is the ME slide. This is brand new. You're going to see a couple things on here that are new. I've got it listed out, peds, adult. Adult side, I have for your cardiac arrest, you see up there, it says the 5 mg of 1 into 250 bag. You have your asthma, you have your nebulized epi, which is, you're going to see the protocol, you have your anaphylaxis. Then you have your infusion. What is our goal for infusion? You have also push dose epi. We'll go into a slide about that. So you are now going to have push dose epi. This is great for some of these really sick patients who you're about to intubate or someone who's decompensating. Really, really important. And do you notice you have no push dose epi in peds? Right? That's not really a good thing to do for peds. We do have an epi infusion though, start an epi drip. That's about it. And then obviously, I'm not going to go to all this indications, contraindications, pharmacology. You guys can read that on here. All right, next slide. This is your HSTs reference. You'll click the hyperlink, and this brings you to this if you have a student or somebody else who wants to know what the HSTs are, and it breaks it down in even more detail if you want. This is a great learning slide. Next slide. All right, VTAC, VFib. Still, you're doing your 1 to 10,000 push, right? That's your first drug. Then you're going to start your drip, 200 mics per minute. But you're only going to do it for basically three shocks. That's it. Okay? 3 rounds is essentially what you're doing it for. Now, if you convert from VFib VTAC into PA systole, what do? Leave it on. It stays on. If you go into VFib VTAC or PDA and it stays in VFib or VTAC, likely VFib, now you're going to fall under this protocol. So after the 3rd DFib, you stop the epi. Why? Well, electrical storm. Too much epi, you put the heart into electrical storm, you start getting this persistent VFib, VFib, VFib. That's why we're cutting back on the epi in VFib. because it's not doing our patients any favor. I predict probably in the next 10 years, we'll probably come out with esmolol and other drugs to really throw at this. No one's doing it yet because esmolol is incredibly difficult to titrate, and I see people drill apply it. So, down below, amio or lidocaine. Over here, you're going to see a nice little comment. If you do amio or lidocaine, it causes torsades. That's why we don't like doing that too much, right? There's actually literature that shows that. So that's a nice part of your pearl that says why we don't do that. And then if you look at your mag sulfate, you've got sodium bicarbonate, you suspect metabolic acidosis. Now, if you're a BTAC and you have someone who did cocaine, do you want to get bicarb?
Mm-hmm.
Yeah, sodium channel blocker is sodium, right? So I didn't write that there, but that's something you need to think about and you need to know. Now, if you look in our overdose section, you're going to see it there. But I can't put everything on this. And that's the point I want to make. We tried to put everything on there. It doesn't work. It makes everything jumbled and confusing. So just beware that not everything's going to be on every single one. All right, next slide. I have a Ross slide. We're still going to Levophed. The literature still says Levophed is much better than Epi post Ross. But I do have a caveat in there, is you can go add on Epi if your patient is Epi sensitive. We've all seen them that, yeah, you got to really push the Epi or they keep coding. Well, let's start your Epi drip, right? That makes sense. They're not responsive to Levophed. Let's start Epi. A lot of patients will be responsive to Levophed. If you have a patient who's symptomatic bradycardia, post Ross, and you're like, man, they got a pulse like 40 and I'm feeling it like that 40, you may want to stick with Epi. I'm giving you those options of how to navigate in taking care of your patient. It's not hard set rules. It's be a clinician. Right?
And your dose for Epi for Rosk is the same as?
You're going to go to Epi drip.
Is it a Brady? You go to the Brady protocol?
Yeah, you go to the Brady protocol after that. Yeah, you're just going to move to different protocols, but you're going to see there's an Epi drip. I think it's mixed. You'll see how to calculate.
Everything is
Yeah.
at 200 mics per minute, but when you get Ross, it goes 2 to 10 mics per
2 to
minute.
10 mics.
So you establish the rate you feel is good for the patient.
Okay.
Here's something that's really important. I put some sedation options up here for you. This is what we have in our armamentarium to like sedate people. More importantly is you're going to hear me complain about blood pressures. It is no mystery that these machines suck if your blood pressure is too high or if it's too low. They're not very good. They give you erroneous blood pressures. Manual blood pressures is what we need to start going to. We're not the only ones doing this. We're probably a little bit behind the curve on this because it's just creating havoc with our patients. We're discovering that, oh, the machine said they are, 70 over 40. Well, actually, their blood pressure is like 60 by Pulp or 55 by Pulp, and they're lying in front of you. You don't have to, you got to act now. Get your push dose Epi, let's go. If it's really high, we had a case yesterday. Remember that? Who was on that case?
Our whole shift.
Yeah, so we had a patient who was acting all altered, her blood pressure's through the roof, machine wouldn't take it. They do a manual, she was 190 over 130. Yeah, something really high. So do manuals. That'll give you an accurate assessment of your patient. All right, next slide. STEMI, new drug. Nitroglycerin infusion. Okay? The dose of the nitro to start is 5 to 10 mics in the STEMI. Max total dose is 25 mics per minute. Who don't we give nitro to? Inferior? You're close. What do we do? Yes, erectile dysfunction drugs, yes. If I have an inferior MI, what's the next thing I do?
Right side.
Do a right-sided MI.
So right. Yeah.
Right. So you don't want to give it a right-sided MI. And we have a recovered there. But this allows you to titrate. So this is one of our new drugs. I also have a pain management on there. Somebody said to me the other day, hey, our old protocols don't have any pain management for STEMI. And I'm like, well, that's true. And I really don't care anymore because I came out with these. So now we have pain management. It's just the right thing to do for the patient, right?
Well, we had it on the chest.
I did have it in her chest. Okay, good. So, yeah, I haven't looked at it in a while. That was too good to do. So, this is This is kind of what I really like for STEMI. Just so you know, there are two drugs we're not going to have anymore. Betalol. And then also we're getting rid of solumental. All right, next slide.
Here's the last one.
That's the last one. Just keeping you in suspense. All right, so this is your nitroglycerin drip. Pediatric, it says online medical control only. I can't think of an instance I've ever started on a child unless they were a severe cardiac patient and I had their peds cardiologist on the phone with me and they said, please start nitro. That's the only time in this world I would ever do that. Otherwise, you have your CHF pulmonary edema and you have your ACS STEMI. We're going to go on the pulmonary edema one here shortly, but our dosing is wildly different. If you look at it, very, very different. All right, next slide, please. A flutter. Not much has changed. I did fix the formatting here, just so you know. No, the formatting's fine. This one's the other one I think. Stable. Biltizum, I gave you 0.25 mg per kg. Slow push. Max dose 20. If refractory, max dose 25. And you have your parameters there. Systolic blood pressure, greater than 100, heart rate greater than 150 for it to be indicated. Over 65, what do? I say give less. Now, I am still okay if they're less than 65 years old. If you're like, you know, I'm gonna pull up 20, 10, just to make sure because the blood pressure is like 110 over, 70. And let's give 10 to see what happens to that blood pressure. And then if it's okay, I'm gonna give another 10. Remember, what can you always do?
More.
Always give more. What can't you do?
Take it away.
Right. This comes from the guy who pushed 20 on somebody and they became bradycardic. Okay? Don't do it. It sucks.
Not many people here have given that. Those who have will tell you that over 10 minutes on a syringe is almost impossible.
Yeah, I have that on there. I have that up there.
Because they'll be like 1 cc, and then we're gonna wait like another minute, and then 1 cc, and then we're gonna wait.
Do it slow.
So
That's just illegal. What they recommend.
I know. So have we considered maybe like in a 50 lag and just let it start over 10 minutes? That's still slow,
I don't care how you want to do it.
right?
I could care less. I just want you to get it. Yeah. You have some latitude here to figure things out to make it work as long as you don't violate protocols. I don't care if you do this. I don't care if you want to sit there and do this. It doesn't.
Nobody sits there and does that.
By the way, I know nurses don't do that. I can't tell you no nurse like, hey, did you give it to? Oh, yeah, just gave it. I'm just sitting there like, oh, look, their heart rate's down to.
That's why you get that.
So just, do I think you have to follow? That's the recommendation. All right. Obviously, if that doesn't work, if your DILT doesn't work, you're like, man, this patient is. Let's give some amio. That's your next option. Now, if your blood pressure is soft, let's say it's 98, you're maintaining fine. You don't need to be cardioverted. You're like, man, I'm not going to get DILT for that patient. What can you do? Here, amio, right? All right. Next slide. Oh, we do have an infusion dose of amio now. 1 mg per minute, just so you know. Okay. Look it up. Make sure you know it because if you convert someone on that drug, I want you to put them on drip. Got it. All right. Bradycardia. This hasn't changed too much except atropine is on there for stable if they're really bradycardic and we think it's vasovagal or something like that, okay? That's the only time really atropine is kind of indicated. If you have someone who's got a heart rate of, let's say, 40, and they just look like for some reason they're holding their breath, they're vagaling, I don't know what they're doing, but you're like, it's narrow complex, let's try a little atropine. Go for it. You can try it, as long as it's not like a 3rd-degree block. Besides that, your other part of the protocol is exactly the same. Next slide. We do have a CHF pulmonary edema now. This is where your nitroglycerin infusion comes in. You can do the nitrous sublingual. Remember, how much is in a sublingual nitro? 400 mics. When I say 0.4 to 0.8, that means you give 2 doses of 0.4, right? So 400 mics, and then I want you to start infusion. I want you to be aggressive with the infusion. If you want to start with the infusion right off the bat while you're putting them on BiPAP or CPAP, you can start at 100 mics and up titrate to 200 mics. The goal is to maintain a blood pressure just above 160. So for your really hypertensive CHFers, like your hypertensive crisis CHF, they're forward pulmonary edema, they're like 180 over 110. I'm okay if there's no contraindication. You start your nitro drip at 100 mics per minute, and then up try to like 120, 140, and doing it rapidly over the next 5 minutes.
Then it's strong IV push.
So I thought about IV push. I'm a little less eager about it. I want to start with this, and let's see how this works, and then we'll move on to IV push. Few agencies have done an IV push, but we've never even had a nitro drip. So we're getting there. But that's what I want to do. So this is important. Know this protocol well. You're going to come across these patients, especially in our community.
Does it say maintain 160?
Yeah, 160 systolic. Yeah. I didn't do a map on that one. Most of them you're going to see a map. Everybody knows what a map is, right? Yeah. Most of our protocols follow maps. Map of 70 unless it's a TBI, it's a map of greater than 90. This one, I decided to put a blood pressure on there.
Right. Right.
All right, next slide. Narrow complex tachycardia. I've changed things around here a little. We do have adenosine twice, 12 milligrams, and then it goes into diltiazem. We do have a protocol for somebody with WPW, which is amio. Okay, unstable, very straightforward. Any questions about that? Next slide. Next slide. LVAD, unchanged. We do have a differential section on top. And then I have a VAD reference to the back, which has a lot more detail. Next slide. I don't think I put it in there, but there's a huge VAD section back there, which actually says what is an LVAD, what can go wrong with an LVAD. It's just a lot more information than what we're trying to do. All right, environmental anaphylaxis. Someone brought this to my attention. I did this on purpose. EMTs here, we do have a very, very small number. They can give under your supervision a 1 to 1,000 IM if they've been trained on it, or they can do EpiPen, right? That's nothing new there. Besides that, it falls under you guys. If you look at our signs and symptoms, this tells you what mild is and what moderate to severe is. And then if you look over on your treatment under P1, you have mild, and then you have severe. We do have a new drug, dexamethasone we've had, it's 10 milligrams. So let me just clarify one thing. Right. Severe reaction includes mild reaction meds, right? Not at all. So we do dex, Benadryl, albuterol, epi, and then Pepsid. That's our new drug. Why do we have Pepsid? Right, it's H2. Absolutely. Benadryl blocks H1, Pepsid blocks H2. Any questions about that? I do have an epi drip built in there. I do also have epi push dose built in there if you need to for those really, really sick people.
Minor detail, but do we need to highlight Pepsid for?
It's already done. I just didn't want to redo this lecture. I've already highlighted. It's going to be hyperlink. Yeah. Let me just tell you, yes. Or this is in excess like 40, 50 hours. So the one that I think we probably caught most of it at this point. So there's still going to be some minor changes until January 1st. And the other thing about the protocols is changes will come out every 6 months if we need to. The only time you're going to see me change a protocol emergently is if we discover we're doing something that's harming people. And then I am going to change it immediately, and it's going to come out with a bulletin saying, hey, we're making this change now. Besides that, it's every 6 months, and it's going to be based on feedback from you all on errors you find or things that need to change. Okay?
But hyperlinks are gonna work in the That's what we're looking, that's what we're hoping.
The
Yes.
hand's heavy.
likely we're gonna move away from PPP, I think. We're
Yeah.
gonna hit,
If we go to hand therapy, we're gonna move away from,
yeah, we're gonna go away
Triple
from PPP and then we'll just use hand therapy. And I know for a fact that hyperlinks work within hand therapy. Not only that, it's divided into sections. You can literally click, 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 and then you're at your protocol that you need. Yeah, and it does do the calculations for your meds for you. All right, next slide. Push dose epi again. Everybody knows how to make this. You take your cardiac epi, 1 milligram in 9 cc's of normal saline, and then agitate. If you don't agitate, what happens? You're gonna end up getting that 1 milligram right off the bat. And that makes it into, if you push 1 ml, you're getting 10 mics of epi. If you push 2 mLs, you're getting 20 mics of epi. 2 things. 1, you can kill somebody with this. So don't get it wrong. 2, make sure you label this syringe. I remember one time the nurse forgot to label it, and we had all these syringes sitting out, and I had them clear out the whole room of every syringe and start over again. Because we were afraid someone was going to flush with a milligram of epi into our patient.
I would also, when we did this in the hospital, I would also suggest not using a flush to like just take 1 cc out, put 1 cc back in, because those flushes are sticker on there. So the milligram, it's not exact. I would pull 9 into a syringe and
Yeah.
then 1.
I would for sure do it that
The
way.
way it's.
I'll let you guys figure out how you're going to make that an efficient process. That's up to you all. But just know it's 1 milligram of epi and 9 cc's of normal saline, and agitate it, and then label it, and then give it. Next slide. This is a really simple breakdown of how to do it. I'm not going to go into this, but it'll tell you. I stole this from a great website. All right, next slide. You all will have access to this, so you can look at this at a later date. Pepsid. Great for allergic reactions. This is also indicated in P's. It's, gosh, does that really say that? 0.25 mg per kg is what it's supposed to say. I need to make that fix. Max dose 10 milligrams in P's. All right. But otherwise, the only other indication that we have is GERD for a pediatric patient. And it has to be diagnosed. Can't just be parents. I think he has reflux. No, that's not good enough. It's got to be diagnosed with GERD or having a GERD attack. Okay. All right, next slide. Hypothermia. I do have a hypothermia protocol in here now. Nothing really special about it except you can hook up your warmer and use your normal saline on it, right? Next slide. Hyperthermia, we have this protocol. We have some resuscitation guidelines on there. I do, if this is an option at a high school and you have someone who's hyperthermic and they got a core temp greater than 104 and they're altered and they got a dunking tank, you're going to dunk them. Because everything you do in the back of the ambulance is not going to pull them down fast enough. They're just going to die incredibly slowly. You're just frying your brain. So you're going to dunk them in the tank until their core temp gets to 102 or below. We do this for the marathon every year a bunch of times. It works really well. And if you're going to dunk someone, you need a lot of hands on deck to do it.
You don't even have to put your whole body in there, just there.
Right here. And
Yeah, I bet.
Let's say the hospital, let's say the school doesn't have one. We have a big old trough here. Can we come to the station and take the patient out? Hold them in there? Okay.
And we do that for the marathon because we have so many and the hospital can't keep up with what we do. That's why we do the marathon. I wouldn't do it for here.
Okay.
Next slide.
oh, it's not for you. We talked about this.
Senator. You can do a body bag, and we can talk about doing that. But still, what is it required?
Nowhere near.
And you like 2 full fullers dumping him in there. Yeah.
Fluid warmer?
For hypothermia, you can use your warmer that you use for blood. Give a warm IV fluid.
But you want us to take that out of the city and transport it with someone? It's like the fluid warmer.
Yeah.
Took it off.
The warrior light.
We want to be able to give blood.
Yes. If you're gonna save a life giving warm IV fluids and you don't have a call pending that's potentially giving blood, yes.
They have warm RV fluids without the needle.
Without that warm.
Whatever you wanna do, however you wanna do it, I don't care.
Maybe it's something we need to bring up to him so we can buy another one. Have two.
All right, we do have an adult environmental, these things, all that kind of stuff. We do have a spider chart for reference as they do come up. I've got brown recluse in my garage before. Bursa for muscle spasms. Next slide. Oh, go back. We do have the acetaminophen. You can get it here, PO. You're going to see we have a new drug. We got offer meds. Now we have IVs, acetaminophen. You'll see that come up. Next slide. This is your spider chart in the reference section. It's hyperlinked. You can easily look at that. All right, next slide. Environmental drowning. We do have a drowning protocol now. Really, you're going to look at it's very straightforward. It's just you're doing CPAP, or you can do BiPAP and then duodeps and put and that really is what. Next.
For pediatrics.
No, we're not on pediatrics yet. Getting there. Environmental barotrauma. So the reason why we have a barotrauma protocol, you're like, we're really diving around here. Well, actually, you get people that go dive. But more importantly, we also have a lot of hyperbaric chambers that are popping up around here because they think it's the new cure-all for everything. So what they do, they're diving into pretty deep depths. And they're going to come and say, hey, we think this guy's got a vent. Better go and do. Really, there isn't much for you to do, as you can tell. That's really about it. Now, if they do tell you to lay left lateral down, it's because they suggest that he's got an air embolism or she's got an air embolism. That's why you do. So if you ever hear someone say that, put a Tremellenberg, head down, left lateral, because they do that.
Currently in the hospital that have hyperbaric chambers with the Herman, Ben Cobb, and.
Nope.
No.
Herman and UTMB.
Okay.
Yeah, UTMB is the big dive catch-all for the Gulf. The big dive center. All right, next slide. All right, next slide. That's my prompt. Take a sip of water. All right, medical management. Small sip of water. New meds. IV Tylenol, Toradol, Droperidol. Okay? I have a pain protocol in here and it addresses all those. Do you give PO Tylenol and IV Tylenol to the same person? No. All right, good. Toradol, great drug for kidney stones, great non-narcotic drug, right? Fentanyl ketamine, 0.2 mg/kg, that's not news for you. You know that one. Droperidol is brand new. Really, migraines is a very rare indication for droperidol, and the person who is having the migraines, they need to answer a few questions like, have you been diagnosed with migraines from a neurologist? Yes. Have you ever had an MRI? Yes. Does this feel like your typical migraine? Yes. Okay, then consider droperidol. But if it's any no to any one of those things, if they're like, this is different, this is worse, it could be a subarachnoid, you're not getting droperidol. And if you have a question about that, give me a call.
So,
Droperidol, by the way, had a long history of having a black box warning for a long QT, but it's it still does cause long QT, but it's not to the rate of what they thought. It's just as bad as Zofran and everything else. So that's why we're going to use it, and it works really well in agitation. All right, next slide. This is the Optimed. This is your new Tylenol IV. Dose is the same as PO. We have it for peds, as you can see on top as well. Next slide. Obviously, liver disease you don't want to give it to. Toradol, came in 15 IV or 30 IM. That's been cut in half in the last 10 years because they found that there's no benefit to giving 30 or 60. Give the other doses. So we changed it in the hospital to that dose. P's, very cautious. We want greater than 2 years old, right? Don't want to give it to the little ones. Go through contraindications. Do you want to give it to someone who's pregnant or breastfeeding? Absolutely not. Not a good drug for pregnant at all. All right, next slide. Droperidol, you can see your dosing, agitated, excited, delirium. We'll go into that in detail in a little bit. You have it for migraine. If they're less than 16, we're not giving it to them. It's the only times we step out of our normal PEDS numbers, and we say 16, okay? Learn about it. You can get akesthesias. Everybody knows that they're kind of moved. They can't sit still. There's a variety of symptoms. What do you do to fix someone who's having those kind of reactions? So on bottom.
Right, then drill.
And a drill. All right.
Style.
All right. Next slide. I have a abuse neglect slide. This is important. And I know because we come across it. Is it's on you to report it. You write in your note, I reported it to the nurse at the hospital. That's fine. It's on you to report it. It's on me when I want to report it. If I don't, that outcome, I am liable. That's why I do have a little hotline thing or something like that. All right, next slide.
I want to catch up this. It's easier because a lot of times nurses are busy. Whatever their ratio was, 1 to 3, 1 to 5, 1 to 7, they forget. So it's easier for us to come back and just file it. Because then they give you a confirmation number, and there's no.
And you're welcome to do that. Just tell them where they are.
Yeah.
Yeah. If you're like, this is heinous, we got to do something, I would report it for your standpoint, report it, and then let the hospital report it. If both of you are reporting it, it helps having your view of what the house look like, plus what they see the patient.
Doc, do you
Yeah.
want to be informed about those type of situations legally? Nothing? Okay. I don't know, like if there's a. Okay.
I've already considered liable since you all weren't handling my license.
Once you get a confirmation number from APS, CPS, you put out a report.
Yeah.
It's on them. At that point, it's on them.
Okay.
Ultimate status. There is no solution to this except here are many different protocols you can click on depending on what's going on with the patient. It's just as a guide. Yeah, exactly.
Which one of those you want?
Correct. Next slide. Hypertensive emergency. All right, so I don't give a solution because there are many causes of hypertensive emergency. If you think this is going on, you probably need to call me because we may do something a little different. For the rest of these, refer to the protocol. Next slide. Hypoglycemia, not much has changed. We got our dextrose, everything else. If you're wondering about the details of dextrose, click on the hyperlink, and then you can go into the protocol section. Next slide. Hypoperfusion, I give you a bunch of reasons why. Click on that, and you come up with your solution to the problem. We have different types of shock. I really like this slide because it makes you think about what kind of shock am I dealing with: hypovolemic, distributed, obstructive, cardiogenic, neurogenic. So you can kind of go through that list in your head and be like, which is this going to fall under? It does fall under one. Fall under one. Next slide. Nausea, vomiting. I did do this. Ondansetron, you can get 4 to 8 milligrams. 2 doses of 4 is probably what I would do if they're really painful. Next slide. Oh, go back. 12 lead. Don't forget a 12 lead in your nausea and vomiting. I've seen multiple STEMIs because they just are nauseous or vomiting. So, do 12 lead. Overdose. We got a lot, right? There are a lot of things overdoses you're
Definitely
going to come across. It's not, we're just like the one morning.
Hey, Sean's gotta flip the slides.
Yeah.
So, overdose management, as you can see, we have a lot. We have beta blocker toxicity.
I'll find it.
Is there, oh,
So under beta blocker toxicity, you have normal statement. You have epi. You push dose diffusion if you need to if they're unstable. Under calcium channel blockers, calcium chloride, normal saline. You can even do an epi push or infusion. We also have under both beta blocker and calcium channel blocker going to your hyper, and then calcium will go to your hyperglycemia, which really doesn't do much, but your hypoglycemia does glucagon, and that actually helps in beta blocker toxicity. If you're doing that, I would suggest just calling me and letting me know because that's kind of stepping out of the normal realm of what you do. But then we can discuss about how much glucagon you do. Cocaine, obviously we had that there, that hasn't changed much. And then the rest of them actually were in our protocol from before. They were just squared out year round. All right, next slide. Next slide. Do the arrow on the right. All right. Seizures, this is different. Versed, right? Start with Versed. If they're still seizing in status after you've done 2 doses of 10, go give them ketamine. There's a lot of research right now about how ketamine can stop refractory status epilepticus. Now this is for adults, but the same thing is for peds as well. Anyway, so yeah, ketamine, 1 mg per kid. Give me a call for that one if you're doing it. Yeah. Because I want to know the outcome of it. All right. So that's the big change for your ketamine for seizures. Yeah.
So, almost positive Western's protocols have been maxed out at total or so.
Okay.
Do you want us to ride in with them with ketamine?
Yeah. Yeah, you could give another 10, and then you bring your ketamine along, and then
We're gonna do that with any medicine that someone else is using.
yeah, you're gonna have to. Here's the deal: if you're being called in, you're taking over patient care. If you're taking over patient care, you're doing this. You're following these protocols. You're not following their protocols.
No, I'm saying Westview coming to Bellaire, and then the Hunger.
Yes, I would ideally like if we can fix problems. They don't fix problems.
Unless you become their medical director.
Yeah, why don't you just do their medical director?
Yeah, they
too?
need. I'm not gonna get rid of the person that's there now. He's a good guy. And yeah,
Unless they want to.
unless they want. But and they wouldn't have these protocols for a while. Next slide. Let's move on. Sepsis. I do have a sepsis in there. Obviously, we have medication options here. I gave you epi, but I told you hypotension refractory to IV fluids and norepi. Start with norepi. And this does not mean you have to do IV fluids first and then do norepi. If they're really sick, you can do IV fluids and norepi at the same time. I do that a lot. It's just better resuscitation. Next slide. I do have ultrasound thrown in some of these, just so you know, use your ultrasound. New drug, stroke. If your patient has a blood pressure that's greater than 185 over 110, you're going to start nicardipine. Nicardipine is a very potent calcium channel blocker that will drop your patient's pressure very efficiently. You need to watch it, be very careful with it. Your goal for stroke is to get it just below 185 over 110. We do not want to drop them down to 120 over 80 because you will cause basically a hypoperfusion stroke on top of their stroke. It's just going to be bad. So you got to watch the stroke very carefully. Now we say 5 milligrams per hour. That's what you started at. If you're finding you're dropping your patient's pressure too quickly at 5, go down to 2.5. Okay? It's really important. Go ahead, next slide. This is your medications for nicardipine. You don't do this in peds. Acute stroke knows exactly what to do up there. Max dose is 15, but again, if you start at 5, it does too much, go down to 2.5. Preeclampsia, eclampsia, if you've gone through your MAG and you're still crazy hypertensive, you're worried about it, you can start nicardipine as well. Okay? That is an option we have. If we say we started for someone who's really hypertensive, and you call me like, hey, I got someone who's like hypertensive, they're altered, kind of like the lady we saw yesterday, we think it's like hypertensive, encephalopathy or something else going on. And they have a MAP of 120. Where are you going to drop that pressure? Anytime you drop someone's pressure, you want to drop it by 25% of their MAP. Okay. Here it says 20%. Go with 20 because you're going to hit 25. Okay. Do not lower more than 20% of the MAP goal. So, my MAP's 120. What am I lowering it to? close. It's like 95, 90, 95. Dirty math. Okay, that's what you want your math at. Don't go lower. Why don't we want to go lower? They're used to their brain being perfused at such high pressures that if you drop it down again, you're going to get hyperperfusion in the brain, you're going to stroke them out. Don't do that. Don't be that person. Okay, really, really important. I really want to stress that with this drug. It's a super dangerous drug, but it can do a lot of good. A lot better than labetalol. Okay, if you be a pulse now, this will be on the pulse. Any questions about that card?
Real quick, we're just still doing either systolic or diastolic instead of criteria.
Yes. So in stroke, it's different. It's not so much about 20%. The reason why is I can't give TNK or TPA to someone who's got a blood pressure greater than 180. So what I'm doing is creating an environment so when we walk into the hospital, they can pull out the TNK and give it right away if they meet criteria.
So the
that
220
what you're
systolic
asking?
is normal.
Or if
You
it's
know,
to one or the other.
185. Yes, but
So I think he was asking in the previous protocol if it was 20 over 110, it was either of it. If it was
less than
220.
185 over 110.
But it's systolic or diastolic is over those numbers you can treat. You don't have. to
Well,
go
let's do
over
this.
those
If you have a
numbers.
blood pressure of 150 over 110, check them in. Always check them because your pulse pressure there is so narrow, it's unlikely they're perfusing their body. So you got to be a little bit smart with it, right? Like this doesn't make sense. Now you get someone who's got blood pressure of 220 over 90. That's realistic, right? Start something like cardio. Make sense?
Mhm.
Yes. Next slide. This is the race score. This is great to have. I put this in there because I think it's a good score. It tells you like who's got an LVO, a large vessel obstruction rate. You can see your scores greater than 5 LVO, greater than 1 CVA. But our reality is this, it doesn't affect us too much because all we do is go to comprehensive stroke centers. And that's all I would ever take a stroke to. Don't ever go to a primary. Always go to comprehensive. And that's basically go to the med center. Good? Next slide.
Southwest is still comprehensive stroke in the middle, right?
I think so. Guide emergencies. So this kind of looks at your postpartum bleeding, etc., and how to resuscitate. If blood is not available, obviously normal saline. If they're bleeding out and hemorrhaging terribly, what do we have? Let's fix the problem. And we're going to get a little more aggressive with that as well. All right, next slide. I would use the arrows on the right.
Oh, okay. I got it.
Yeah. Mental health, this has changed. And because not everybody fits into one category or another. So mild agitation psychosis, do Versed or droperidol. See the or? Moderate and Versed and droperidol. And then you have severe life-threatening agitation. This is the one likely you're going to see more often than the other two. But if you have someone who's just being kind of a pain in the butt, and they're thrashing around a little bit, you can control them. You're not doing it for behavioral reasons. You're doing it for care reasons. And they're altered. They just don't make sense. They're moving. They can't hold still. You're like, I got to get a 12 lead. I got to get an IV. And they're just really agitated. You can give them a little Versed. That's the option that I'm giving you. Okay. With severe life-threatening, Versed up to 20 milligrams. Then move on to your ketamine. Why do I like part of it? A lot of times they're really dying,
Mhm.
right? They're dying. So that's all we're going to do.
So
Any
that's
questions about this?
a new P2 skill section added into the other P2 stuff, right?
That is now P2.
Okay.
I don't want my P1s making that decision. I want it to be a P2 that makes that decision.
Makes sense.
Because there's a lot of liability behind that. There's
Mhm.
a lot of decision making behind that. That's why. All right. Next one. Hyperkalemia. We see it. It's about time we have a protocol for it. Okay? Yes.
Mm-hmm.
Makes sense. Nothing you don't already know, except I probably put albuterol in there officially, and so it's easy to follow. I think this will be much easier training along these protocols, to be quite honest with you. They flow really well.
Yeah, a lot better.
Next slide. Airway general. So we have something new. DSI. Who's heard of DSI? I know you have. You do it out there. You have. Yeah. So we're incorporating DSI with our RSI. Late sequence intubation, and then you have the rapid sequence intubation. You all right? Negative. Ketamine etomidate. Nothing's changed, right? That's all the same stuff. We're using rock. We're not using sucks. Sucks is a terrible drug. Next slide. Huh? It should be 1.2. We have
Yeah.
1. I know 1's the dirty way. It's really officially should be 1.2. So I have 1.2 mg per kg. Okay. So delayed sequence intubation. I want you to think about the patient who's hypoxic, flailing around. You can't get them to stay on the CPAP or BiPAP. You're like, I gotta intubate this person, but they're just not. This could be a trauma patient, it could be a medical patient, it could be whatever it is. You gotta control them and get them oxygenated. Their stats are like, let's say, the 80s or 70s. A lot of times, what you're gonna do is what you're gonna do is going to be make for ketamine. Okay, ideal body weight, make for ketamine. And what that does, it puts them into that K hole. They start breathing. They'll start breathing the BiPAP. Breathe with their stats that come up. You may find in some cases of medical cases, particularly not so much in trauma, by giving them that ketamine and then having them sync with the BiPAP, they actually start fixing themselves. You don't even need to intubate it. But majority of the time, you're probably going to still have to. And what you're going to do to oxygenate, you can use a DF or BiPAP, non-rebreather. Always do with the nasal cannula as well. Flush it with as much oxygen as you can. Get their sats up, and then once their sats are up in the mid to high 90s, that's when you push your rock run. Does that make sense? Yep.
Mm-hmm.
Read through this. It's really important, and it's going to help you. Next slide. This is a very dirty way. I don't have this in the protocols, but this is a very easy way of quickly thinking about this. I suggest looking at this. Yes, you should.
Or
Ask your commander. You don't get it yet. Our girl will be on the share drives. You can pull it. But this is I think this is a great way in your head of how to think. How am I walking through this? APOX, see on the bottom? That's just your apneic oxygenation. Don't forget about it. It's really important. Any questions about this? The difference between this and RSI is RSI, you're going sedative, rock, intubate. This is sedative, wait, oxygenate. Oxygen sats up. Do I still need to intubate? Yes. Okay. Push rock. Or sedate, oxygen sats are up. They're looking better. They're actually looking pretty good. Let's hold off on the intubation.
How long do you recommend waiting on that medical patient if the ketamine starting to work for us to make that clinical decision?
So the
We're so
oxygen
close.
should start coming up fairly soon. You're going to wait till you're not going to intubate someone who's sat around 70%. Because what's going to happen?
Right.
They're going to die.
Mm-hmm.
I mean, they're already so far down that curve. So if for some reason you have them, let's say they're breathing, syncing with a BiPAP, their sats are still in the low 80s. Give me a call and let's talk about what we can do. You may have to switch over to bagging them and trying to fix the problem that way. Or maybe there's something in their history that we need to understand. Like maybe we have a patient that comes to my ER all the time with sats of 85%. He's got this pyruvate deficiency, some rare disorder where his sats will never go above 85%.
Oh.
So, I mean, we'll have to talk about it. All right, next slide. But for the agencies that I work with that do this now, they don't really have this problem. Yeah. Here's your advanced airway. Basically what it is just saying a little more in detail about what you're going to do. I don't want to belabor this. It does note one thing that you want to put in there is half-dose induction agent for unstable patients. I think most of you know that. Give half-dose of etomidate, half-dose ketamine, and if a patient is unstable. Usually they're altered as well. They're half sedated as it is, but just that's Ketamine, ideal body weight. Learn how to calculate ideal body weight on your phone. Download MDCalc or one of these other apps, and then figure out how to do ideal body weight, because that's how you got in trouble. That's how the guys in the whole round. All right, next slide. We're going to have a pit crew approach to airway when we're intubating someone. We're already kind of doing this, but now we're making it more official. You're going to have one person who's going to be the paramedic in charge, who's a primary patient care oversight. They're having the 30,000-foot view, making sure everything's getting done on the intubated patient. Then you're going to have your airway man who's going to be actually doing the intubation. And then you're going to have the two assistants. You have a person doing medications and the monitoring, and then you have the other person who's handing the bougie or the tube or whatever else to the person that's getting. We are kind of doing that, but we need to define who's doing what. It's just like a cardiac arrest. Except this is actually even more dangerous because there are a lot, right? Cardiac arrests are dead, but when you have a pit crew role, it works really well. But here, we need these roles defined. You'll run smoother, you'll go much better, and you won't have errors. Next slide. Somebody called me about a patient who is intubated, who's tearing and looked agitated. So this is the Richmond agitation scale. This came from Richmond Ambulance, where I used to work a long time ago. It's a quick way to figure out, do I need to sedate my patient? And on the bottom, you can kind of see what guides you as whether they need more sedation. If you have any questions about it. It's a very dirty, quick way to figure out, do I need to give them some ketamine or I need to get some Versed fentanyl? Okay. When we sedate someone with Versed, do we get fentanyl with it? Should, right? This person take care of pain? Yeah. All right, next slide. So this is a vent troubleshooting algorithm. It's more information on how to troubleshoot your vent. So if you want to improve your SpO2, it tells you how to improve your SpO2 by going up on the F5 or going up on the B, right? You want to improve your end-tidal, ways to improve your end-tidal, go up your tidal block, go up your respiratory rate. And it sort of walks you through all these different things. It explains a few things under diffusion. It looks at perfusion, like how to calculate that, and then ventilation. It's a good little cheat sheet of what does the vent do and how do we look at it. Now, if you have problems with your vent, you have a patient decompensating on the vent, the first thing you need to do is the dopes mnemonic, DOPES. We'll go over that in a minute. But when in doubt, things aren't going right with the vent, disconnect them from the vent. And then you will learn a lot about your patient just bagging, right? Wow, this is marked bagging, or well, this is easy bagging. It's got to be something else. My tube's not strong. Stop. Next slide. This is what I'm talking about right here. Dose. This is a very quick way of troubleshooting a patient decompensating on the vent. Disconnect them. First, make sure your tube's still where it's supposed to be, right? Splits. Next, is your tube obstructed? So if you're having a tough time bagging, you're going to want to patch the suction catheter into that tube because you have a leak split. P, do the thorax. You can use ultrasound to figure that out, right? Listen to breath sounds. Look at your patient. But is there pressure taking while they're on the vent? Going to be a new agent to catch. Equipment failure. Easy fix, right? PPM. And then stacked breaths. This is for your people who have asthma or COPD. And what happens is they never exhale fully. If you've ever bagged someone who's a bad asthmatic or COPD, you hear that. Right. Squeeze the chest, get all that air out. Because what happens is that intrathoracic pressure gets higher, higher. Preload drops. They get hypertensive. They can be well. So be smart about your patient on has COPD or asthma. They're dangerous patients on vents. All right. Very dangerous. All right. Next slide. All right. We have a reactive airway disease. We have UMNet, DEX, Epi, MAG, all your typical stuff. We do have a Epi nebulized on there if you think it's some upper airway edema. So if you think you have stridor and it's not wheezing, how do we tell the difference? Very simple trick. If you want to tell the difference to someone who's wheezing or has stridor in a kid or an adult, if you listen to the lungs, you hear wheezing. You're like, I hear wheezing. I think it's stridor. take your stethoscope, put it right here. If you hear, that's strike. If you don't hear anything here, that's.
Yeah.
It's so I didn't know that either a long time ago, and
I know that put them like here for obstructions, you can listen right here.
can a lot of evidence that sounds
Mhm.
That's why they say. So it was actually someone who talked to me because I didn't know. And I was treating someone as an asthmatic, and it was a long time ago, so it turned out they were close.
Right here.
They still have a little bit of. All right, next slide. Pneumonia, I did put that in here. If you suspect they have a pneumonia or they didn't diagnose the pneumonia, we've got a big geriatric population. A lot of medication options, right? Basically, what I'm doing is saying you can take care of the fever with Offermed, right? And Tylenol, or you get PO if you can handle PO. If you're hypotensive, start some norepi, you can give albuterol, some normal saline. If you're going down the sepsis route, obviously saline and then Levophed at the same time. And then, God forbid, if you have to go into the really hypotensive patient that's not, fix themselves quickly, you do push dose epi or EpiPen. Now, the push dose epi can work in a patient that's just so hypotensive, you're trying to get the Levophed out. Do a little push dose epi while you get your fluid and your Levophed going. Okay, it's a nice little bump to get them to where they need to be. So if you're dealing with somebody who's got blood pressure 60, let's hang the Levophed, let's hang the fluids. Hey, why don't you draw a quick push dose epi? Let's get them up and let that Levophed start working at a higher pressure, okay? That is an option that you have. You don't have to wait for the Levophed. You can give a little bump on push dose. Yeah.
So our oral Tylenol is in 500 milligrams out. Here you have it weight based there.
Yeah, I think it's up to 1 gram. How many adults do you know that aren't going to make to 1 gram?
Right.
There's some that won't.
There's some that
So
won't.
just be close. Yeah. Just, if they weigh 50 kilos and you're looking 500 milligrams, right? Or 7, break 1.5. I wouldn't break that. Just get 500 milligrams and say we get 500. Or you can do the opposite. Same dose.
Same dose.
Yeah. And adults actually we can do 1 gram. And actually, I don't know why it says.
I was gonna say, it sounds like it should just say 1 gram.
Say 1 gram. We're coming up with a few little things I gotta change on this.
Okay.
All right, next slide.
These don't go into effect until next year anyway.
January 1st-ish. Pulmonary embolism. We have patients that are diagnosed with it. There's some options on how to treat it. We don't want to give a ton of fluid to these patients. If you imagine they have an RV that does not push very well against the clot, you start giving them a lot of fluid, what happens? That's what you think about it. It's not going to be fine. So we try to limit the amount of fluid we get there. These are patients you really suspect it, or they've been diagnosed with it, they're home with their decompensating. Both of which are possible. Next slide.
Drink more.
Drink some water.
All right. Traumatic injuries, hemorrhagic shock. If you're giving blood, we're going to give calcium and TXA. Now, who are the 2 patients we don't give TXA to? The big ones that we think about. One is going to be your GI bleeds. There's no use of TXA. Recommendations, okay? Everybody got that? Yeah. All right, next slide. Traumatic arrest. Again, you can do blood, fast, bilateral finger, thoracoscopy. If you give blood, obviously you're going to give the calcium and transsuccinate acid. If we don't think they need blood, they're not hemorrhaging out, that's not why they died, it's from something else, then you can do just the transsuccinic acid, or, if you feel like you need any other fluids, you can do that. Blood's available, so you still have this protocol in case you don't have blood. This guideline is not for obvious traumatic death. There to see it. Next slide. Electrocution, get a 12 lead. And remember secondary trauma, and there's a big difference in carrying between someone who's touched a high power line versus a low power line, right? We all know that. There's a huge difference. Touch a high power line, they've got major problems. They've got burns through their entire body. Low power is a little less likely to still get PTSD.
Doc, does this include taser deployment as well? Taser deployment? Okay. Taser.
Next slide. Fractures and amputations. New drug. Herceptin. It's an antibiotic. So if you've got a nasty open fracture or nasty amputation of a long bone, you're going to give Herceptin.
Is this only for obvious open fractures?
If you have an obvious fracture here and you have a small hole in the skin right here, is that an open fracture?
Yes.
That's an open fracture. Because that pointy part of the bone just went, beep. That's all it is.
And this is the only time we're giving this as of now.
As of right now, the reason why I chose Herceptin is because it works really well in your nasty open fractures if they're like grade 3 dirty open fractures. But also down the road, I predict us identifying sepsis and then starting antibiotics early to assist our health. Those are the both drugs given a majority of sepsis.
What is the TXA slow?
It decreased distal perfusion or skin tone. What's the what?
Why is the TXA getting slow?
You always get TXA. I think it actually, I can't remember the reason. Cause hypertension. I can't remember. But you always give it slow TXA. It's going to drip it in. Yeah.
2 and 100.
If you're giving blood.
So 1 and 2 and 100 over 10 minutes.
Yes, it's going to be in the pharmacy section.
Click the hyperlink.
So you said TXA if you're giving blood.
Blood.
If we're not giving TXA, if we're not giving blood.
You can give TXA. If you don't have blood, you can still give TXA. If you're like, this patient's bleeding out, we don't have blood, give TXA. Now remember, TXA is also now indicated in patients with head injuries, right? That you suspect that they bleed.
You give it rapid, it causes hypotension.
That's
Oh,
Hypo.
all right. Any questions about this? Next slide. And I do realize this is a ton of information I'm throwing at you, but this is why you guys have plenty of time to study it. Get to know it. All right, this is just a card on Herceptin. The dose repeats is 50 mg. Slow, drip it in. Max total dose is 2 grams. One time you don't give it is if they're allergic to stuff. So you have to ask before you give it. That's the key.
If they're allergic to what, sir?
Cephalosporin. So right there, so just look at your protocol if you have a question about what that is. All right, next slide. We have spinal cord injury. I added norepi in there in case you do have a spinal cord injury and you know, let's say you're not bleeding or anything else and you need some pressors and they're hypotensive and they're not tachycardic. That's a classic sign of spinal cord injury. Starts in the morning. Take the blood pressure up. All right, next slide. This is your spinal mobilization reference. Basically, what this is your nexus criteria. Do we still put people in a collar because they have penetrating trauma to the neck?
No.
So this is wordy, but it's in your reference section for you to look at. That's why I put it in the reference section. Wordy things go in the reference section. Yeah.
Have we or can we consider full body splints instead of back?
I mean, backboards are strictly for
We're
moving purposes,
not
not for
using
transporting.
backboards anymore. We shouldn't be using backboards unless you're moving someone from point A to point B.
then you take them off of it.
Or if you have a strong suspicion that they have like a fracture along the thoracic or lumbar spine.
Could we do the scoop instead?
That could be good.
A little more comfortable than that back leg.
Like that's with that thoracic or lumbar fracture. It's got to be pretty significant. Like if you have someone who's paralyzed
Okay.
face down,
But like an autopay can be one of those, like, and you don't know what's going on.
yeah, but we've also proven that we move them around, we pull them out of cars, and it does nothing. It doesn't change.
The injuries
So
are.
the new recommendation is don't let them sit in the car for decompensating. Just get them out. don't do all this KED crap and all that stuff. Don't get them out. Start resuscitating. I don't think I've seen a KED deployed in 10 years.
I can't tell you the last time we deployed them here.
EMT school.
There's a lot of-
When I was started here, we
This
did.
is ours. I like this because it flows really well. Nothing changed here. You guys know this already.
Like, we need to get rid of that. We need to go to full body split. The moment somebody reads this, they're gonna be like, oh, gotta put them on a backboard. Gotta put them on a backboard. And full body
Yeah,
splints,
we do have to take out the backboard.
full body splints,
Well, you have to do that.
you don't have to worry about it. You put them on the splints and everything and boom, gone.
Can we get it back?
We can't. I mean, we just gotta,
That's
the
a good
supervisors having to go down there or the medic units when they go back.
So midline.
But we're not using these.
Midline C spot center.
Even out west, we've reduced the number of time we're using them.
Is
Full
now.
body slam?
Yeah, they're like, we're just going to like a collar.
Backboard.
I wouldn't leave them on the backboard.
Oh, we can see-
Unless there's a strong reason to have them on the backboard. Actually, I'm not worried about this.
We've gone to scoop on our ship.
I'm just gonna take.
Yeah, on our
Yeah.
ship, we love. to
We scoop. I mean, I prefer the scoop because it's easier to transport. It's more comfortable for the patient.
Go back a slide. If I leave it on this is fairly explanatory. Just leave it open. If I get rid of the next one,
That's fine.
so I need to get rid of that. All right. TBI, TXA is now added in there. Remember your H-bombs? I put that under your pearls, your H-bombs, the things that kill people with head injuries. Hypotension, hypoxia, hyperventilation, or hypoventilation, to be honest with you, right? That's what kills them.
So I thought you had someplace where you hyperventilated.
We don't do that anymore.
TBI,
Yeah,
that's gone.
it actually causes vasoconstriction. You just normal ventilate. Normal ventilate.
I'll have to find it because I questioned it and I forgot to ask you about it.
We don't want to hyperventilate. You don't want to hypoventilate.
Right.
So what's, no, question.
Go ahead, because they
The question is like, your body compensates by itself. If you have a TBI and this guy's breathing at 20 times a minute, your body's doing it for a reason. So what's the literature behind taking away 20 and going to 12?
I think that's why they were saying hyperventilate because they're
Well, there's a lot of
already
reasons
there.
why he's breathing at 20, right?
Sure.
I mean, it doesn't necessarily
Injury.
against TBI. It's just the injury in general. They have an effort or whatever, like everything's ramped up. So the key is you don't want someone to have a very low end tidal and hyperventilated. And you don't want someone to have a very high end tidal. And because what happens if you have a high end tidal and you're hypoventilating? And your stats are also going to drop, right?
Sure.
That's one of the H bombs. And you definitely don't want hypertension. So really what we're trying to prevent is we want your patient to stay normal intensive, have normal sats, and then have a CO2 that's not going to cause vasoconstriction.
So we just take their airway.
But you got to be careful if you take the airway,
Absolutely.
everything can go sideways.
Yeah.
Right? Any other questions about that? Go ahead and next slide. Oh, if you go back one, it does say maintain in title 30 or so-ish. That's about right. Gives you a little, that's a safe zone for your entitled. But that doesn't mean you're gonna be like this to get to 40, right? You gotta be careful with that. Trauma, compartment crush syndrome. This is a new one that we have. Couple things about this. Apply tourniquet to the affected limb prior to release. So if someone's got their whole arm stuck in a grinder and you're about to get them out, put the tourniquet on right before you get them out. Why? What's gonna happen?
No, you don't want that.
The lactic acid and everything else is going to start flushing. They can actually get profoundly hyperkalemic. They can go become acidotic and die in front of you. So you got to have them on the monitor too, right? And also, while they're being crushed or whatever, you may want to consider starting doing some calcium and sodium bicarbonate just to take care of some of the effects of that potential hyperkalemia and acidosis. This is why we created this. Really important to have a resting.
How many minutes?
So it's not defined. If you're responding, they're prolonged. They've been there for a while, probably, would be my guess. Figured it out themselves for a little while. You guys figure out if they're there for 5 minutes and you get there and you get them out, that's not long enough for this really to take place. But if they've been there 20, 30 minutes, I would really be a little concerned. All right, next slide. Trauma and pregnancy, we addressed that. Found something misspelled. Next slide. Oh, wait, go back, real quick. Go back one. Left lateral is mentioned in there, obviously, and then manual displacement of uterus, you can do that as well. All right, next slide. Next slide. Perfect. Sexual emergencies, I got a bunch listed here. The big thing is, if we suspect an ectopic, do a fast, because if they have free fluid in their belly, what happens? They're dying, they're bleeding out. We also have blood on here, right? Blood is an option in these patients if you need it. They're unstable, they need criteria. Preeclampsia, the dose of mag has gone up to 4 grams. Fentanyl is safe in pregnancy. It's a class B drug, so you can use fentanyl. But otherwise, it really just kind of goes into all these different scenarios. I do have the carpine listed under eclampsia. We have mag sulfate, 4 grams. We have Versed. And then we have like cartipine, advanced, we have all these things under eclampsia that you potentially may need, okay? So you can walk your way down this protocol. Any questions about this? Next slide. This is your neonatal resuscitation. Nothing's changed here. It's just laid out a little differently. I think it's easy to follow. Same thing as before. Next slide. Pediatric protocols. Remember this. I keep getting questions about this from different people, like what's the max dose, what's the max dose? Well, the reality is max dose in peds is almost always what the dose is in adults. Don't ever, there are very few drugs exceed the dose of adults in peds. It's just a good safe rule. The only time we ever do that is for otitis media, really with amoxicillin in kids. That's like one of the few cases I can tell you that we do. But besides that, don't exceed the adult max dose. All right, next slide. What slide number are we on?
81 and 145.
Are you guys doing okay? You want to keep going? I think a lot of this will be faster because a lot of this thinking.
Very blurry.
Yeah, there could be some blurry. I'm sorry. Remember, medication options consistently. That's if we don't do the same thing in kids. We do pushes of drugs, right? We don't do drips. It's not the same. Really, nothing's changed here, except I've given you the bicarb calcium as part of your protocol. All right, next slide. BFib, BTAC, same thing. Andio or Lido or MAG. What's indicated? What's right indicated, right? Andio is usually what you're going to be going with. Remember, no drips in kids. Pushes. Next slide.
So you have.
Yeah.
You already answered it, but. So we're gonna have the P doses back on the protocols, but then we're also gonna have the hand-setting links to give the exact.
You're going to have the ability to go under hand setting weight, age, actually mean by age, and then it'll
What we have in the old protocols, that we had the Excel spreadsheet type thing that gave you all the drugs, and then that's not in there anymore. That's gone.
All right, so Ross in peds. We do epi-drip in kids, right? We don't do leave-it-fed and Ross. We do epi-drip. This is where things get a little fishy because you're gonna have to know this by heart. So certain things in peds, almost everything in peds, you do epi-drip. The only thing we don't do epi-drip in peds is sepsis. And we leave-it-fed. Right. All right, next slide. Bradycardia. Stable, you can give a bolus if you want. Really, if you're stable, right? If they're unstable, you have different options. You got your push for epi, you've got your drip for epi, you've got atropine if their increased vagal tone is suspected. And then you've got obviously pace. And just remember, if the little kids, if their heart rate is less than 6, like start compression, right? And sit over there in their clothes. Any questions about this? I do want to point one thing out. What is the most common cause of bradycardia in kids? Fix hypoxia. If you fix the hypoxia, you fix the heart rate. So all these drugs are great, but won't do crap if you don't fix the hypoxia. Okay? That's the important thing to know. Next slide. We do have kids from TCH that have CHF and pulmonary edema. Now, these kids are kind of unique. I do have to see why they have on there if they're big enough for it. A lot of times what you're going to end up doing, you're going to show up at the house and they're going to have the doctor on the phone. Talk to the doctor. These are one of the few times I will tell you, listen and do exactly what the peds cardiologist tells me to do. Because when I'm in the ER, when I used to work at TCH, I would do exactly what the peds cardiologist told me to because they do some weird stuff and they have very good reasons behind it. So if the family says, yeah, they're a peds cardiologist and they're like unstable, be like, can you get your doctor on the phone? Maybe try to call them. If not, get me on the phone and we'll kind of work our way through. I do have norepi as the hypertensive agent on it. Epinephrine is not necessarily the best thing to do in these peds cardiac patients. And if you say start it, I don't know. At this point, I found out these patients are so brittle. Talk to that doctor. Next slide. There at complex tachycardia, we do have a change here. Besides the adenosine times 2, I've added amio. That's the new thing to go for narrow complex that doesn't convert with adenosine. Right? It's a new thing to do. Next slide. Allergic reaction, Benadryl, Dex, Epi, albuterol, Pepsid, 0.25 mg per kg. And then Epi infusion, if you need it. Pepsid's our drug, right? Next slide.
Epi infusion or epi?
If you need it, Epi infusion. We don't do push dose Epi kits. It's hard to, that likes, it's quite a bit. So we kind of would prefer just going straight to the brain.
Does a certain dose have that ability?
That's different. For what? Push dose?
Yeah.
I couldn't tell you. I think for push dose Epi, I'd rather you draw it up.
Sure.
You know exactly what's in the syringe than doing certain dose. The certain dose, I don't think you can do. It's too small of a syringe. It's completely different. Yeah. All right, bites. First set for muscle spasms. Next slide. Pain management. We have Tylenol, we have the Offermin, we have fentanyl, we have ketamine. Next slide. Abdominal pain or GERD. All right, I had Zofran. Do I get Zofran for every abdominal pain in a kid?
No.
When do I get Zofran in a kid with abdominal pain?
Nauseous.
Right, they're throwing up or they're nauseous. So that I do want to make that clear, especially when you have someone who's very black and white with protocols. You need to be very careful with your FTOs out there and make sure they understand, like, hey, this isn't meant to be given to every abdominal pain. I have it on here as an option for medication in case you have abdominal pain. It's not just like an acne or something like that, right? I just want you to have options to treat symptoms. GERD must be diagnosed with GERD when you get it. Next slide. Yeah, your responsibility to report. TCH is really good about this. I'll be honest with you, if you have a kid who's probably does it too, but TCH has a whole system in place to get this stuff done. So if you have a suspicion, you report it to our nurse at TCH. Social work will be in the room next.
So I know for now that Bentab was the only hospital that had sane nurses. So
That's sane, yes. Yeah, so Ben Todd had same, but apparently these have them now too.
Target one thing.
Yeah, apparently these hospitals have it too. That may change.
No, that's fine,
Yeah.
I'm just, back, only then Top had them because
Yeah.
we did that research and they were the only ones.
I think the others had them, or used to have them on call, so you
Yeah.
have to call in head
So,
thing or there was.
yeah, so what happened was there's a lot of complaining about that, so I think all the hospitals have the option. Big push. Next slide. Hypoglycemia. It's kind of the same thing you've been doing, right? Start your drip, glucagon. If you need it, I wouldn't do too much glucagon in kids if you can avoid it. Try to get the IV item. There's really no need for glucagon these days unless you think they're going to die before you need some. How long does it take glucagon? It's like 30 minutes. Yeah. Does it work if someone who's got a cracked liver? Never anything but that left. They have no glycogen stores. So.
I see oral glucose is not on there.
Oral glucose is always an option. It is under, do I have it under there? No, but do I need to write it on there? I do have it under there for the pharmacy section.
As long as it's a pharmacy, you're fine.
Yeah.
Yeah, it's in
Yeah.
the pharmacy section. So. I don't want to because it's just gonna get so big and so confounding. Like, I'm trying to prevent the protocol we had before. Like, I just don't want that to happen again. It's just too much. You guys are smart enough to know, teacher, new medics, like, hey, we have oral glucose. I know it's not written on there, but you need to give oral glucose. All right, next slide. Hyperperfusion, same thing as adult. I go through the different causes of hyperperfusion. You can click the hyperlink to the next one. Next slide. Nausea, vomiting, Zofran. Dosing is a little different, as you can see there. You may repeat it once. Max dose is 4 milligrams. Okay, that's what you work up to. Next slide. This is your overdose. I can guarantee you probably most of this won't be addressed. Your overdoses for kids, like they just, unless they're clearly unstable, you're not going to start an epidural or a beta blocker that they took, but you're going to get into the hospital. As always, call poison control. I think they're very, very helpful in these situations. Next slide. Seizures, a little different dosing, but again, we have a dosing for IM and IM. Do we wait for an IV or do we just give IM? IM.
I had a question for the previous slide. Do you know if every state's poison control is different, or is it all the same?
It's all the same.
They have the same guys, but they're different the way they're run.
Right. So I bring that up because if I doubt it for myself, when I'm going to get Florida's poison control, if a New Mexico guy calls, they're going to get New Mexico. If a Nevada guy, that's what and we have a lot of people from out of state. California guys will go to California next.
I called recently, and that's, the woman on there was like, "Are you in Myrtle Beach right
They'll
now?"
transfer you.
But
We should be
she
getting
answered,
TMBs.
Well,
it was, she said, the way she explained it was, it's like caller ID. Doesn't mean I'm going to that one, but they see where we're calling from. That's how she explained it.
But my question is, the end result,
It
are they
doesn't matter,
different?
it's still the same.
Use the Unify. I think that's a solution.
She still talked me through it. It wasn't, it's still the same across the country what they say.
Let me just get a Houston.
Yeah.
Anyway.
You were questions, other comments?
Yeah.
All right, next slide. Any questions about this? I do have Ocrevus on there for kids with febrile seizure, unless they're awake now and they're talking and they're looking good, and you can give a Tomahawk febrile. Yeah.
If we gave them Tylenol, that helps them.
If they're calling you, you're getting a med, you're taking it. Yeah. You're good. I do not want to see in the habit of putting in IVs, getting drugs, and being like, "Oh, see you later."
We'll have a
Yeah.
You're good now, right?
Peds sepsis, norepi. That's your first one. That's your first line in the kid. Joe Gill and I had a long talk, and we talked to TCH, and You still find some different schools of thought, but our thought behind this is, why am I gonna start with a big gun when I can get away with a lesser gun? And there's no reason why we can't give norepinephrine. And TCH is giving norepinephrine to a lot of their kids. They finally got away from dopamine. Terrible problem. So if you get pushed back, just let me know. And I'll talk to whoever it is, but we're gonna go with norepinephrine on these. I think it's the right thing. And then if that doesn't work, you go to Ed. Next slide. Try fluid bowls first though. Kids respond to the fluids a lot better than the adults do. A lot better. Rui, who's heard of this? Yeah. Brief, resolved, unexplained event. Used to be old Alti. Who heard of Alti? Apparent life-threatening event. That's what that used to be. So Rui is just basically, you can kind of read about it over here and tell you exactly what it is. Somebody who witnessed something go wrong with their kid. Episode up there in the history, infant or child greater than 2 years old, that is having a frightening to the observer and is characterized as some combination of the following signs or symptoms: apnea, skin color shade, fluid overload, muscle tone changes, choking or gagging, not associated with eating or something like that. This is what falls for that for gagging. Honestly, 12 lead, really nothing else for you to do except put an IV and get fluids if you want. Then bring it to the hospital. Next slide. Hyperkalemia kids. Yes, we have TCH nearby. We got some weird stuff. This is how you treat hyperkalemia. So really not different from adults. Next slide. So, take a drink of water. Yeah, go back so I can sit.
I like that name.
Airway general, we do not RSI peds. I'm not going to change that. I think it's just a huge liability, and all the literature says that there's some terrible outcomes. That being said, I do know some agencies that do it, and they do it. One of them that I work with, they do it. Their medical director, I'm MD2, their MD1 is like, hey, I want to keep it. I'm like, okay, man. But the problem with RSI kids, one bad case, and it's all over. So I've chosen to go the non-RSI route because I think it's safer, one, and I think we have tons of literature that shows that we can maintain pediatric areas with a BVM successfully, and not only that, we buy gels, we have other adjuvants. Yeah. Yeah, but you're just, I don't try to think that way.
Yeah,
That's not how I like to treat obviously not with these protocols, it makes no sense, right? Or I feel like we shouldn't do anything, we should be like Westview and just go.
saying that, but
It is what you
risk risk versus reward.
Don't make this tape public. Next slide. Airway, advanced airway. These are just most intubations. They're intubated and they wake up, start waking up. Next slide.
3504.
P3 airway disease. This really isn't any different, to be quite honest with you. If they're greater than 2, we're kind of treating it like asthma, right? We're going to go down the asthma route. I do have ketamine on there for sedation from why it's written there, okay? If you got a normal BiPAP or something like that, you need to calm them down. Now, if they're less than 2, you can mild distress. I added in there, made a little change, do it. If they're in severe distress, we're going to need to epinebulize for bronchiolitis, okay? Does that make sense? It's not every kid needs a nebulized epi. They'll be fine with just a duo. But in some cases, you can be like, man, this kid looks rough. Let's do the nebulized epi. All right, next slide.
So now it's 0.5 milligrams.
Put out.
0.5 milligrams.
Yeah, that's what we had before.
You had three mLs of epinephrine.
Yeah.
3 mLs of epi.
Yep.
Well, it's supposed to be 0.5 milligrams nebulized to 3 mLs. No, there you
Yeah,
go.
that's a six.
That's a typo. So why
Who are doing?
Yeah, we're not doing that anymore. That stops today. Stops right now.
Mike, you hear that when you do
Doing
that?
this.
Speed test with them?
For the guy you're testing tomorrow, in 2 days. He's gonna be.
Yeah, I'm gonna tell you right now, I'm doing that. All right.
Like YouTube fan.
Oh, you're getting.
Next. Ready? You got pneumonia? Okay, so pneumonia gives you options for sepsis also, otherwise treatment, and then, really not any different than the adult. Next slide, except for dosing. This slide I really like. I stole this from Fort Bend. You've got croup and epiglottitis, and it tells you the difference. Epiglottitis is terrible. It's really bad. Those are the kids you don't want to touch too much because what happens is the epiglottis swells up and it can actually slim shut over the trachea, and then you're done. You're not getting elucidated. You're not able to bag through it. They say you can forcibly sometimes bag through it. It's almost impossible. So this tells you the difference between croup and epiglottitis. And what do you do about it? Epiglottitis on the bottom, I would really look at this as really important. Epiglottitis is keep the kid calm and do some blood buy and get it to TCH.
We had a severe one. Westview ended up transporting, but you could hear them the minute we got out of the engine. They were just.
That's
really,
probably
really bad.
would be my guess.
Yeah, it was true.
Yeah, so up there is the croup. Nebulized epi, 0.5 to 1/1000 of 3 mLs.
They did that, and by the time they got to the hospital, the kid was.
Turn around. Yeah. Maybe that's because we got 3 mLs of epi. Decadron. And then you can do either PL or the Aquamed. Any questions about that? It's really not any different except I put epiglottitis up there. All right, next slide. Peds trauma. Guess what? You can now give blood to peds 10 cc per kilo up to 1 unit. All right. It's important to know. All right. So that's what we're going to do for kids. Calcium transfused acid, you see it there, same thing before. Next slide. Traumatic arrest. Not much different. We don't do finger thoracostomy in kids, right? We do needle decompression. Next slide. Fracturing amputations, you have Recefin in there. 50 mg per kg, total up to 2 grams of what the bulk dose is. That's for your open fractures or your amputations of long bones. Fingers, part of a foot, part of a hand doesn't really count. I want long bones. Okay? Everybody know what the long bones are?
What about an adult? What about an adult?
Same thing. Same thing. Yeah. All right, next slide. Yeah, go back. Yeah, so I taught air traction split and stuff like that, right? So the reason why we're reducing, if you have a bone that's critically angulated and you don't have a pulse, the best way to restore that pulse is to get it back into somewhat of an anatomical position. Now, sometimes that artery gets severed. It's pretty rare. Usually that artery just peaks. But the longer you let that extremity go without blood flow, you're increasing the chance and lactic acidosis and everything else. Basically, it's like a crush injury, but not a crush injury.
Right, so I'm going about, you know, it's like I understand traction split.
Call me, FaceTime me, but what I almost always do is you look at it, oh, that's not the right position, right? You turn the foot this way, or pull and get it into the position it needs to be.
Close.
What do you mean close?
Close traction.
It depends on, it depends.
When we get our cadaver class, can we dislocate and stuff and then can show us how to
I
put
don't
that?
know, it depends. It's hard to do that, they get kind of like a little sketchy about that.
So
Yeah.
we might need to get things because it's discounted.
Is this?
Oh, yeah.
Some of the other busy agencies that I work with, what I do is have them call me and FaceTime me, and I'm like, all right, I want you to track it.
Like it.
Not everyone.
I could just see people like out there.
You guys don't see that too much, but you're gonna see it at some point. You're gonna have someone's leg behind them, and you gotta see something about it.
I need to upgrade the truck font to an ice.
I really
Yep.
think we do, because there's been several times recently where we've called you, gotten advice, and needed to send you pictures, and we can't do that from the phone.
Yeah. They just suck.
I do.
Yeah.
Fuck back in nineties, yeah.
Yeah.
But those are, when we're reducing things, that's probably a good time to get me on the phone. If you're like, hey, I gotta reduce this, and can you somebody walk me through it, and I'll walk you through it. Sure. I have no problem. Even if I show up, I may have you still do what I would. Just so you can express, unless you're one of these people who are
Corrections
gagging or
straightforward.
pass out, and when you start feeling all the bones crunching.
I'm imagining someone 2-year-old angulated really bad, and we're out like pulling on it.
They're gonna scream, but
Everyone's
also
fine?
trying to get an IV in and get her slug of fentanyl.
Colin?
Next slide. All right, ocular trauma, we have this for peds, just don't touch it, don't push on it. We also have this for adults. Covered but no pressure on it, and then Zofran prophylactically, because nausea, vomiting increases the intraocular pressure, and if they got a hole in their eye, all that stuff will come out. All right, next slide. Spinal cord injuries, again, this is one of those that you do Norepinephrine in kids. That's what we've decided. Next slide. TBI, gold map, greater than 90. I got to change that in the adult. Gold map is greater than 90. Here, gold map is greater than 70. But in TBI, you want to perfuse the brain, right? We don't want to hyperperfuse the brain because that kills brain cells. Nothing's really different here. Next slide. Carpet crush, nothing again. Prior to release, place tourniquet, and then there are your medications. Same thing as adult, just different dosages. Quick question about pelvic binders. How do I know if pelvic binder is on correctly? First of all, if I can't see your belly button with a pelvic binder on, it's way too high. It needs to be going across your pubic symphysis and here. This is how low a pelvic binder goes. I can't tell you the number of times we stand and look at a pelvic binder come in on, oh my God, it's not doing a damn thing. It needs to be down here, going here just above your genitalia. That's pretty much where it goes. If you're any higher than that, all you're doing is crushing the belly. And you're actually hitting your iliac crest and you're making all this go like this, which makes it worse. Yeah. All right, next slide. What slide are we on? 114? Sweet. All right. Amnio. Peds narrow complex, these are indications. Infusions are now included. If you convert a rhythm, it's 1 mg per minute infusion. Okay? Give a pump now, you can figure that out. Then there should be pretty easy. Next slide. Dextrose. Here's your dextrose. Glucose. Right there. I know that makes you happy.
Going back to having Ethan.
You're going to have that option. I put it on there because sometimes we run out of stuff.
Okay.
What's that?
P50, having that as an
So
option.
I will tell you that, your first line should be your D10. Because D50 is cheap. The one we got, I had it on back order for a year. So
I have it up there for a reason, in case we ever have it.
Because I don't want to have to go back and edit. So it's up there. Next slide. Diltiazem, definitely don't do it in kids, but you can kind of see the changes we made there. They should reflect exactly the protocol, which is good. Next slide.
So D10 250 mLs vitamin.
Should equal 25 grams. I don't know what our dosing is. That's what I put up there. Yeah, I want you to do the 25 grams. You can do 250. Now, if your patient starts turning around, you check a blood sugar and you're at 125 and it's at 120, do you have to finish the whole thing?
the initial dose of the old protocol was 100 pounds.
Yeah.
125.
So
125.
how many times have you given 125 and you've been short on a patient and had to give more?
Yeah, I'm just asking.
Yeah, that's why I've doubled it up. Duoneb, we have it for peds. 1 dose of Duoneb in peds, and you're going to move on to albuterol. Okay? They don't need all that ipratropium. Next slide. Epi, I think we've gone through this one ad nauseum. Look at it, know it, because that's probably one of your key meds. Ketamine, you have here as well. We have pain management. I do have intranasal ketamine for peds and adults. Ooh, it works. Yeah, it's not bad. Yeah, some little intranasal ketamine, you can do that. That's an option. Next slide. All right, blood. Peds is less than 16 for blood, okay? There's one other drug where it's less than 16. Which one is that? That we don't give. Droperidol, right? Next slide. Blood. We're going to stay here for a second. Our criteria changed. Okay? I want one of the following. But they all have to have hemorrhage suspected. Okay? Everybody has to have bleeding. That is the bottom line. If they're not bleeding, you don't think they're bleeding, don't even walk down this route. Don't even bother. There's no point. But if they're suspected to be bleeding, they could have a heart rate greater than 120 and that'd be their only criteria. Okay. If you think they're bleeding that much, give the blood. MAP, less than 65, or they meet the pediatric criteria of a low MAP. Modified shock index. This is a very, very helpful thing, and I would do this on every blood patient because they could have normal vitals, but their modified shock index is telling you otherwise. If that index is greater than 1.2, something is wrong, and they need blood, okay? Now, again, they must be bleeding because you can have a modified shock index greater than 1.2 with sepsis or with, just about any other disease you can really think about. But if they're bleeding and their modified shock index is greater than 1.2, you have the green light to give blood. How do you calculate it? Heart rate over your MAP. If it is greater than 1.2, can you see it? Is it just not? It's kind of blurry. You may want to look behind you. So if it's greater than 1.2, your modified shock index, give blood. If your end-tidal CO2 is less than 25, why? Why would our end-tidal CO2 guide us on blood? Well, if you don't have blood, you have decreased cardiac output. If you have decreased cardiac output, you have decreased blood delivery to the lungs. You have decreased blood delivery to the lungs, you have decreased CO2 coming out of the lungs, right? Or in medical patients only, I don't care about trauma. This is not for trauma. But if you have a medical patient who doesn't meet any of those other criteria, but their hemoglobin is 6.5 and they're not like the classic cancer patient that, gets blood every week and that kind of thing, you have a right to give blood. TXA, do not give in GI bleeding patients. Also don't give it in pregnant patients, but you'll see that on the pharmacy card. It is not indicated in GI bleeds. They just had a huge study that showed no benefit. Does anybody have any questions about that?
Do we still need to contact you every time we want to do blood? Or is it just a notify?
You can just notify me you gave blood. Don't contact me to give blood if you meet criteria to give blood. But let me know when you give the blood. Like, that could be a text, it could be a phone call, however you want to do it. Because we're tracking it. Any questions about this? This is very different. You're going to give more blood. You're going to give more blood.
You give blood, send a text to both people.
It's an all page. If they're not unstable and they're not, now if they're unstable and they're like, hey, she's on the toilet with a massive GI bleed, she just got a transfusion, yes, I don't care, you're giving blood. She's dying, you're giving blood. But if it's like, hey, they always get anemic, they're due for blood, but they missed their appointment, and they're completely stable, just drive them to the hospital, let them cross and type match their blood and all the antibodies that they have. But besides that, give blood. Save lives, okay? Mm-hmm. It has to be a separate line for the calcium and TXA, right? The most important thing is to give the blood. Then comes the calcium and TXA. So if you can't get another line, oh well, do your blood. All right, any questions about this? This is a big change for us. I mean, there are a lot of big changes in this, but.
Yeah.
Okay. I am okay. I don't want to give somebody chest pain. I am okay if you guys start using this today. I'm going to put it on you, and that's per the. I am responsible as the medical director for what you guys do, so I am okay if you start using this today. Okay? Blood. Blood. No, you can do TXA and calcium. I'm okay with that. Separate line, but the blood protocol is what I want you to start using today. I think there's enough evidence for us to do this, and I think it's important for our patients that we serve. So,
That needs to be a formal.
I'm going to tell him when he comes back in here. And
Not everybody's.
yeah. I'm okay with this being done. That's on me. That's my decision to start it today. Are there any questions about that? And remember, you can call me.
Yes.
You can call me, and if you're like, hey, shock index is 1.5, give blood. All right? Any questions? We got enough GI bleeds around here for this to be helpful. All right. I can think of at least 2 patients in the last year we should have done this on.
Well, the changes you made, I could probably think of the same one.
Yeah. So, Commander, the one thing I want to tell you is I am okay and for them to start using this as of today. This is in the reference. This is wordy. Now, there are no hyperlinks in the protocol as of yet. That somebody who's smarter than I am needs to sit down and do the 2,000 hyperlinks that's going to take. The what? Yeah, do that too. I would, again, focus on the blood. Hospitals can always give it. There are no doses. Yeah, the dose down here is your blood. PD is 10 cc per kilo, up to 1 unit.
At any age.
At less than 16. Yeah. At any age is up to 1 unit. Yeah, it's always 1 unit, max. Because we only carry 1 unit.
No, I was
Yeah.
following up on like the.
Oh yeah.
If they're 5, they still get 10 mils per.
Oh yeah. Yeah. Any questions about this? As of this second, this protocol is active. Whole blood. Depends on how much we give. We will see. We will see. All right. All good? I know you want a formal bulletin and all, but you can also call me until you see something formal come out and ask me. That is the option you have.
No problem.
Yeah. I don't want things to be held up to start this because I think this is important. Yeah. Fair enough? All right. But I am going to ask you, what's your logic? And then you better give me one of them. Versed, we know the Versed, there's nothing surprising here. The only thing is, you can also give Versed intranasal, just so you're aware. That is an option. Don't forget it. IM is better in seizures. I like it better. All right, next slide. We're happy. We do have it for kids. Just be aware. Next slide. TXA. We have our dosing here for kids and adults. Contraindications, non-hemorrhagic shock. Makes sense. GI bleeding. known pregnancy, postpartum hemorrhage, no use in postpartum hemorrhage. And then do not use if they're on birth control. Because you're already in a hypercoagulable state, and now I'm going to give you TXA. Welcome to a DVT or a PE. We don't really want to do that. Now, if there is a 26-year-old female on the ground dying, bleeding out, and you don't know, give it. Don't hold it. Even if you do know, her problems are so bad. They're so bad that she doesn't have enough blood to create a DVT problem. So that, you really need to just do the right thing here. No one is going to crucify you. Oh, she was on birth control. How dare you give TXA? No one's going to do that. And if they do, you just tell me who they are. I'll take care of it. Next slide. That's not upside down, that picture. Yeah, that wasn't upside down. Don't say that, because there's already some stuff that's all right, ready? Oh yeah, thank you. All right, SAD avoidance. This is really important. Now, this does not apply to your traumatic case, okay? The reason why this comes up is the EMS sucks at this, and we're trying to all address it. We want you to resuscitate before you move the patient, okay? So often we see agencies, and you guys aren't like this. You guys move to the unit, then you start resuscitating, which I'm perfectly okay with. But sometimes you have to leave them in place to resuscitate. If they're really sick and you just get on the road and haul ass to the hospital, what happens? Things don't get done and they die. Right? You have a lot of tools right now to really save a life. And our point is, if you do it, you're going to save that life. And so I don't want you running with a medical patient where you have to do X, Y, and Z on scene to get them stabilized before you move them to the truck, before you leave that scene. Okay? Now there are things that are time sensitive, right? Like STEMI. You may have to pace them en route. You may have, because what do they really need? STEMI. They need a cath lab, right? They got to get to a cath lab. If you stay on scene and screw around with STEMI, you're not really going to get it, because they got bigger problems. You got to get the cath lab. Stroke. Start your nicardipine en route if you need to, right? Like, those are your they're still the load and go kind of things where you need to get them to where they need to be. Now, if the stroke van or whatever is coming to you, fine, sit there and start your stuff and wait for them to arrive, because then you can put them in the scanner and then you can start the TDA. But otherwise, for other things, get them stabilized, work on them, fix them. You guys do that now, keep doing it. But you have tools to really make a difference. And that's what we're trying to say. This protocol is going out to a lot of different agencies in different versions. But I think it's brilliant. And if you look at the stats over there, it really takes into account that what you don't do results in increased mortality. So gone is the day where you're just an ambulance driver. That's not the case. You are now a legitimate extension of the ER. That's what you are. Right? You have drugs that we use in the ER on a regular basis. That's what you have. Now, it's not like that for every agency, but you guys do have that, so use it.
This is the latest study that they put out, kind of like sepsis was a few years ago. Like EMS was missing all kinds of sepsis, needed a big push. This is the latest one of those.
Yeah, we're just not resuscitating. And it's probably it's a big problem for big cities. It's a big problem for rural America. We're kind of in a unique spot between the two. Not even really between the two. We're in a big city, but it's sort of a strange suburbia within a big city, right? Suburbia with big city problems. But otherwise, go through this. This is really important. I want you guys to really embrace this, embrace what you can do for the patients of this town. I think it's really important to understand that. You're a lot more than what people like to consider what you are, and hopefully the public starts realizing that, and I think they are. But you're really just an extension of what I do in the ER. That's what you are. All right? All right, next slide. We are going to start doing NG tubes, gastric tubes, mostly gastric tubes. Go through the OP. We got to do training on this. It's not going to be released probably in January. But when you intubate someone, you're going to drop an OG too. It's not a priority. That is not the first thing you're going to do. It's what you're going to do if they're like hematemesis or something like that. Like they're vomiting blood, then you're going to drop it. It's something you need to know.
We're going to be doing NG tubes too?
OG is much better. You can do NG and OG are both on there. Now it's a lot easier to drop an OG in someone who's intubated than it is to do it in NG.
Yeah.
Right? Right. You took care of the one hole. Now it just needs to slide.
Well, yeah.
You're only doing this to people who are intubated. It's not for anybody else. Okay, go to the next slide. That just kind of shows you how to measure it. Blah blah blah. Basically, you measure it the same way for both an OG and. Next. Field term, unchanged. Basically the same stuff. This is just how it looks. I've made it look a little different. Next slide. This is just a lot of legalese and stuff like that. Remember, 20 minutes is what we want. We can go up to 30 minutes if you want to. Next slide. Vagal maneuver. This is for your SVTs. You just have a formal protocol for it. Hey, bear down like it, take a big poop. Next slide. Go back a slide. Okay, next slide. Withholding resuscitation, I do have a protocol for this now for when you shouldn't do anything. Obvious death, right? These are fairly self-explanatory. Next slide. IO placement, this is going to be new. Our primary point for adults is still proximal humerus. For little kids, it's going to be distal femur. So we're going to have to, I'm going to let you guys, this is not a hard procedure. And you guys need to tell me if we need specific training or not. Go to the next slide. So how you place a distal femur is very simple. Okay? Everybody has a patella, right? You know where your kneecap is, right? In a kid, you're going to measure about a centimeter off and then a centimeter off the midline. Okay? And basically what you're doing is you're going to go lateral. Or medial, I'm sorry, it's a medial. I'm looking at the picture wrong. So you're going to go medial. So your finger is about a centimeter. So go finger up, then put your finger right about the middle, and then go medial to that, and just make sure your needle is perpendicular to the middle. Yep. That's it. That's all you got to do. And it's your way of avoiding the joint. Yep. So that's what you're going to be doing for kids right now. That seems to be the route that is preferred. Is everybody okay with this? Does anybody have issues with this? Does this make anybody nervous to the point where you're like, hey, we better get this? You guys have the ability to do the training here. Have some development, right? So I would suggest just pulling it out, going na-na, and then getting used to what that feels like. All right? Okay. Next slide. Prisoner transport. This is our old protocols. We have this essentially. Next slide. Taser plate removal. This is under, I can't remember, this is the procedure section, so you'll see it under there. It's not really a protocol, it's a procedure.
And with taser deployment, you still are required to do an EKG after the taser has been deployed, or no?
Unless they're complaining of something. Next slide. In custody patient, we had this before, I believe, right? This was ours before. It's really important if you have someone in custody that you use if you don't know what to do, because you're going to be there and be like, should we take it? Should we take it? What is the evidence behind taking this patient? There's now a subject in custody risk assessment score. Go to the next slide. This is going to guide you. Do not give this to PD and tell them, call me if they're in the red. I will lose my shit if you do that.
Good thing you said that, because
I'm just going to tell you, this is not for them. This is for you to justify your transport. Here's the thing, though. If you have that spidey sense, you can trump this. They're never going to argue with you taking the patient, right? So we're like, good, to get them out. So don't let this turn down a patient that you feel like should be transported. Okay? But if there's, you hem and haw and you're like, use this. This is a great little guide as to what's high risk and what's not high risk. Is this helpful? Some of these are kind of funny. Shouting, bizarre behavior, and that's like big belly breathing. Yeah. Yeah. So I'm just telling you how comfortable you feel at leaving someone with moderate risk at that jail. Not. Because who's watching it? Isn't it the video up at the dispatchers? Yeah, that's not.
Yeah, let me ask you
It's true.
a question here. Should we print this and have a hard copy to upload to your EPCR?
To put in the EPCR? I don't know.
I think this is easy enough that we can
Like a little.
Here's the thing. Once we get hands heavy, you want to apply stuff on your phone and start doing the math.
Oh,
Yeah. So what you'll do is you'll go straight to, I think this is in the reference section, the procedure section. I can't remember. You're going to find it, and you're going to hit the hyperlink. And this is in the reference section. The previous slide was in the procedure, but on the bottom there's a hyperlink to it. And then you're just going to look on your phone and then do the calculation. I think that's probably the best way to do it. But again, if your spidey sense goes off, just take it. Don't put that liability on yourself. All right.
Something I think y'all are maybe overlooking is it's in their practices because they have to follow the international police chief's best practices. If there's any kind of medical complaint, like man, I got a
Well,
hangnail.
their procedure is pretty strict. We know that.
Yeah,
I mean, we postpone that and everything, but we know they call us like,
Okay.
because they have to.
Yeah.
Yeah.
18 calls in one night.
No, we're just hoping fine.
Now, at some point, you'll come across someone that says, is arguing with you, well, I think you're fine. I think you should stay here. We have that problem. Every once in a while. But you know what? That's when this comes in handy. He's 11. We're going. We're taking him. He can't be here. Or he's an 8. He's moderate risk. You really want to keep moderate risk here? They may say, yeah, sure, I don't care. But you're going to say, no, this isn't it. This prevents that whole like back and forth. This is your evidence of saying, you know, we're going, because if you get to a 5, it doesn't take much, does it? Exactly. Yeah, by the way, anybody who's sweating should make you nervous.
This opens the door for your clinical judgment, essentially. I mean, this is just a reference. Like, if they're shivering and they're let's say they're sweating, but they're also super active, running around, and they're fighting with the cops because they don't want to be in the man, the what is it, the bundle? What are they called? The ramp? Like, that's going to take them above a 5 pretty quickly.
Well, hold on. They're already in custody. They're sitting in the jail. This isn't even pre-excited delirium. I mean.
You're right.
Yeah. It's a pretty good argument.
If they're 0 to 4, you should be like, okay, then effectively pure or not. And then
This is a guide. This is a guide for you to use. It's not the hard line. This is what you're going to do. This is a guide.
That's fine.
Just like that.
Or you put shouting and profuse sweating together, and that's 6 right there, and boom.
Just say again. I'm going to warn you. Profuse sweating should make everybody nervous. When someone comes in my ear and they're profusely sweating, I stop what I'm doing and I go look at them, figure it out, because something is very wrong. So don't let profuse sweating ever turn you down. Oh, they're fine. They're just sweating. No. Profuse sweating is a bad omen for the human body. It's something bad's happening. So just be aware of that. That's why you always hear ER doctors going, diaphoresis is like, that's hey, you better go take a look. Either they're going to code, or they got a STEMI, or they got something else going on that's going to be really All right. I just want to show this to you guys. I think it's important. Good reference. Next slide. Ultrasound. I included some ultrasound stuff. A lot of this we had, but some of it we didn't. Use this. I sent out a nice, cool little thing yesterday with some cool quizzes. I have images for you to keep up on your ultrasound stuff. We haven't learned all this, but it's stuff that I'm going to have on there because eventually we are going to move a little more into some more advanced stuff. But you guys got to show me you're doing the basic stuff first. And I don't think we're doing enough of the basic stuff. Next slide. Here's the lung. Give you some idea what the lungs look at, but until you guys start doing some of the basic stuff, we're not going to be moving on. I gotta see you guys really using it and embracing it, or it's just pointless teaching it. Next slide. Next slide. This is classic stuff. This is patient refusal. What is a patient? These are laws. If you haven't read this, this will quickly define what a patient is for you. Next slide. Pregnancy drug categories. If someone tells you I'm on this, you're wondering, is that safe for pregnancy? You can look it up online, then you can look here as your reference. Next slide. Are there any questions? What do you guys think of the protocols compared to what we've had?
9-day difference. 9-day difference.
We got to find some 12-year-old who's willing to do it for like $50.